So we performed a study presented as an oral presentation this year at ASH 2020, abstract number 372, entitled Clinical Outcomes Among Real-World Patients with CLL Initiating First-Line Ibrutinib or Chemoimmunotherapy, Stratified by Risk Status, results from a US retrospective chart review. And so what this study is doing is looking at a real-world population of over 500 patients with CLL to see how they did with upfront therapy, whether that be chemoimmunotherapy or ibrutinib, which is a Bruton tyrosine kinase inhibitor. So as a little background as why we did the study, it's been demonstrated repeatedly across clinical trials and is highlighted in CLL guidelines, whether you're looking at IWCLL or NCCN, that all patients with CLL should be tested for high-risk features to inform, how to treat in the frontline setting. So those high-risk features are checked by doing FISH, and you look for 17p deletion or 11q deletion. Those are considered high risk. Also independently, you need to look for TP53 mutation, and that's present in about 5% of patients at baseline, even if they have normal 17p status. And then another factor that's important to check for all patients is the immunoglobulin heavy chain gene rearrangement status, or IGHV. So if that is unmutated, that's considered a higher risk feature. So we looked at patients, charts, about 516 patients. Of those, 271 were identified as having high risk CLL. And among those, 175 were treated with ibrutinib and 96 with chemoimmunotherapy. And the goal of this study was to see in high-risk CLL how patients do. So we performed an inverse probability treatment weighting, which is a standard statistical method to help us balance baseline characteristics and balance the sample size. So we can really look at just, a pure balanced sample in the real world, which is hard to do since your treatment allocation in the real world setting is not randomized. So in this patient group, we used time to next treatment as a surrogate for progression-free survival and found that in high-risk CLL, patients treated with ibrutinib, the median time to next treatment was not reached, compared to those treated with chemoimmunotherapy had a median time to next treatment of 34 months, so significantly shorter time to next treatment. Another way of looking at a surrogate of progression-free survival is looking at the percentage of patients that only required one line of therapy during our treatment period. So this was significantly higher in patients treated with ibrutinib frontline, 74.7%, compared to those patients treated with chemoimmunotherapy. Only 47.2% received one line of therapy in the study period. The remainder required more than one line of therapy. So this study is important because it replicates what we've seen repeatedly in clinical trials of chemoimmunotherapy versus targeted therapy, in that patients with high-risk CLL, defined as 17p deletion, 11q deletion, unmutated immunoglobulin heavy chain, or presence of TP53 mutation, those high-risk CLL patients really should not be treated with chemoimmunotherapy in the frontline setting outside of rare extenuating circumstances. Due to better outcomes, patients really should be treated with targeted therapy. As we also performed some intra-treatment analyses showing that patients treated with ibrutinib, whether high risk or not high risk, had a similar time to next treatment. That was not true for patients with chemoimmunotherapy, where those with high risk disease had a significantly lower time to next treatment than those without high risk disease. So it really highlights the importance and the reason why the standard guidelines are to check all patients for high-risk CLL prior to initiating frontline therapy. So I can say there are certainly limitations of performing this type of study. So a very interesting question we were unable to answer is, how do patients without high-risk CLL do? So we did have a group of patients that did not meet criteria for high-risk CLL, so were considered standard risk, had the absence of all of those high-risk features. And unfortunately, since the two populations were not similar enough to statistically compare, we could not gather any information from this study regarding those patients. But moving forward, we hope to look at other questions like, what's the role of chemoimmunotherapy versus targeted therapy in the non-high-risk group? What's the cost of care for chemoimmunotherapy versus targeted therapy? A very important question in oncology currently. And then what are the adverse reactions? What's the tolerance and quality of life of using immunotherapy versus chemoimmunotherapy versus targeted therapy in frontline CLL? These have implications for combination therapy, time-limited versus indefinite. So a lot of questions to be answered as we have this explosion of new agents entering our treatment landscape.